You can see my slides now.
Yes, we can.
All right. All right. Let me start by saying I don't know whether I should say good afternoon or good morning or good evening because where I am is midnight, is 9 o'clock, and where my co-presenter is about 10 o'clock, so PM. So I should rather use my time zone and say good evening to everyone. I am David Mputi from the University of South Africa, and I am with my co-presenter Ronald Chibonire from the Kabale University in Uganda. We will be presenting our title. Our presentation is titled Overcoming Resistance to Long-Acting Reversible Contraceptives Used in Uganda. Firstly, what happened now? All right. Firstly, what I would like to say as a matter of an introduction, the study was conducted in Uganda, where about 48 of the pregnancies in that country are unintended, and they are contributing to maternal as well as economic instability. Based on that, they are also contributing to most of the young girls or the teenagers having to drop out of school based on the fact that they cannot attend school after they have fallen pregnant. The long-acting reversible contraceptives usage in Uganda has taken a very low uptake of only about 14% of the women in the district of Rubanda, where the study was conducted. And this is despite the fertility and maternal mortality rates, which are very high. The study, we have actually come up with some barriers which are key, in the sense that, first of all, the socio-cultural norms were found to be the causative low uptake, whereby actually the culture itself, as we go along, you will see that how the culture is actually affecting that, the religious beliefs, the misinformation, as well as the male dominance decision-making power. Uganda, as a third world country, is experiencing a high number of unintended pregnancies, and these pregnancies contribute to high maternal mortality and economic instability. These unplanned children, some of whom cannot even attend school based on the family's economic status. This is happening despite the availability and the free family planning services. So it is a problem that we actually had to look at and see, why is it happening even though the family planning services are free. The question that we wanted to answer was, what are the perceptions and the belief systems, as well as the attitude of the rural Bachiga people towards the use of the long-acting reversible contraceptives, and how this influence contraceptives among their partners. The hypothesis that we came up with was negative perceptions and deeply ingrained cultural religious beliefs significantly contributes to the resistance of the use of long-acting reversible contraceptives. We use qualitative following the constructivist phenomenological approach. The location was in Uganda, as I've said, in the Rubanda district, which is based where the study was done in Nyamuero as well as Miko. The participants were 60 married Bachiga men who were aged between 20 and 49 years, And this was a purposive sampling because we really wanted to find out if the men in Uganda are really having an influence on the uptake of the long-acting reversible contraceptives. Data was collected by means of the focus groups, individual in-depth interviews, and we used the semi-structured guides, which were written in the local language, the Ruchiga, of which then after the Ruchiga, the interviews were transcribed into English, and then we asked again somebody, the different person who actually transcribed it back into the initial language so as to make sure that no information is lost. The analysis was done using the thematic approach, of which then the two primary themes were the perceptions of the lax as well as the belief systems influencing the choices of family planning. Ethics was actually received from UNISA, which is the University of South Africa, as well as TASO, a Ugandan-based ethics committee, before the study was commenced. In our findings, we found that we had health misconceptions, we had also social concerns. First of all, under health, we found that people, the men felt that their wives had prolonged bleeding, and then they were fearing that their wives will actually become infertile and not be able to bear children for them. And then they were also worried about the weight gain of their wives, as well as the arm paralysis from the implants which were used. Under social concerns, we found that fear of encouraging infidelity, whereby men felt that if their wives are on contraceptives, they can actually go and sleep around everywhere without fear of anything, and the loss of pregnancy deterrent, as well as fear of social repercussions, including stigma that as a man you are allowing your wife to sleep around by allowing them to use the the long-acting reversible contraceptives. Key findings as we continue, we found that culture, religion, as well, they were also part of the of the obstacles. Under cultural expectations, we found that if men expected to have large families. As an African man, if you have two children or three, then you are not man enough. So men wanted to have more children, irrespective of their socio-economic status. Need for male heirs. You find that sometimes in a family, the family has got three, four, five girls, and the men would be trying to get a male because in an African context, the heir of the family is basically should be taken by a male, by a boy. And then there was also a dowry related wealth because if your child was found to have been using the contraceptives, then it was actually going to lower the amount of dowry you can charge the guy who is marrying your daughter. Then male authority in decisions. Males were actually found to be the key people that are actually making the decisions in terms of the family size, and as well as in terms of the what to use in order not to have children. When we look at the religious, we found that the Catholic and Protestant resistance was also part of the issue because most of the men felt that their religion do not actually allow them to use that. And then there was a conflict with the divine principles by actually thinking that the ancestors will not actually forgive them if they are going to be making use of the contraceptives. And again, fear of losing the leadership roles in the churches. And this actually came up again, whereby people felt like contraceptives are like killing the unborn babies, and therefore some of them even reiterated that I cannot have a woman that will be having some graves in within herself. So we realized that most of the information that these men had, it was actually not so true. It was just a myth. When we look at the hypothesis that we had, we found that strong reservations shaped by misconceptions and cultural norms and religious teachings were the strong influencers on the uptake of the long-acting reversible uh, contraceptives, and that related to us to accept the hypothesis that we had. What the study contributed is that the first in-depth exploration of indigenous Babachigaman's perspectives on lax provides a nuanced understanding of the barriers. Policy implications, we found that there's a need to have included in the family initiatives. Culturally sensitive behavioral changes communication is also one of the most important aspects that we can use. Engagement of trusted community leaders, where we can actually have the community leaders talking to these men after we have actually spoken to them and also convinced them about the use of the contraceptives. Practical applications, we found that training healthcare providers to engage men, because in most cases, when we look at the syllabus, it only talking about females, what females can do in order to do the family planning. The community-based approaches, where we can use the radio and then peer education after training and understanding, addressing gender norms that are actually restricting the women's autonomy, where we found that their male spouses were the main people who were making decisions in terms of the having the babies. The recommendations that we had under community engagement, we found that we need to have more radio programs and then embark on peer education networks, and also go and talk to the trusted indigenous leaders, because in an African context, the leaders, the village headmen, are the most trusted and the most respected figures in the public. Under the health system, we found that we need to provide more training to the healthcare professionals to involve men whenever there is a talk regarding the family planning. We also found that the service accessibility, it should actually be made accessible, because we also realized that some people are also scared to go and make use of these services because of the fear of being stigmatized. Male engagement, I think I've spoken about it. Gender equity, we need to address the cultural norms which are actually taking away the woman's autonomy, and also we have to embark on shared responsibilities that men should have with their wives. Culturally tailored interventions to dispel myths and reshape attitudes toward the use of long-acting contraceptives. As we conclude, we came to the conclusions that male perspectives are critical to understanding and overcoming barriers to the use of long-acting reversible contraceptive adoption in rural Uganda, and interventions must be culturally sensitive, because some people, when you invade their cultural beliefs, that's when you are chasing them away. We need to be culturally sensitive when dealing with these issues, and then we need to include males. We need to address the misconceptions through trusted channels like the use of the churches as well as the indigenous leaders. Engaging men as allies in reproductive health can enhance the utilization and improvement of maternal and child health care outcomes. as we ended, we came to other conclusions that men's involvement is key to improving the uptake of the lux. Cultural and religious engagement is essential for success. Under cultural, we looked at the king or the village heads, and then religiously we looked at at approaching the churches. Shared responsibility in family planning decisions enhance maternal and child health welfare or outcomes. Under the acknowledgements, we would like to acknowledge the University of South Africa, UNISA, which is based in South Africa, and then Kabale University, which is based in Uganda, Rubanda District participants, which actually allowed us, especially African men in Rwanda district, who allowed us to interview them under their strict and very strong cultural belief systems that they are not going to talk about family planning as it is the responsibility of the women. But these men gave us the opportunity. We would also like to acknowledge the ICFP 2025 Organizing Committee for accepting our abstract and allowing us to share our information. I have noted the secretariat in the meeting, and thank you very much for your time and listening. There are our contact details. Dr. Ronald Chichibonire, there is his email and my email as well. We can be contacted at those emails. Thank you very much, colleagues. If there are any questions, me and my co-presenter, we will be happy to can answer them. Thank you. Hello?
Thank you, David. It was really very insightful. I have nothing to ask. I'll come back to you separately.
Thank you.
Should I start my presentation?
Hi, Dr. Jawaria. Yeah, I think we can proceed with your presentation. And many thanks, David, for the great presentation.
Okay, thank you so much. So the title of this presentation is Under the Scalpel, Exploring Barriers and Enablers of Vasectomy Uptake in Pakistan through a Socio-Ecological Lens. I am Dr. Jawaria Mukhtar, the primary author of this study, and my co-authors are Dr. Farina Kulaprejo, Dinesh Majlas Khan, Aga Zahir, Aga Zahirpur, and I'm the research specialist at Aga Khan University, and this is my email address available. So the agenda for this presentation is as follows. So let's talk about the introduction and the background. Family planning is a fundamental right and a critical component of achieving universal access to sexual and reproductive health care. SDGs Target 3.7, FP 2030, and the 1994 Cairo International Conference on Population and Development emphasize this. While global efforts continue to expand access to contraceptive options, male participation, particularly through vasectomy, remains limited, especially in countries like Pakistan. Vasectomy is a safe and effective permanent contraceptive method is only used by 0.1% of married couples in Pakistan. So culturally, And because of religious beliefs, gender norms, and misconception about masculinity and sexual health, and because of lack of male-targeted services contribute to this low uptake of vasectomy. Vasectomy used in higher in countries with better gender equity and health systems, which is our developed countries, but it is below low 1% in many low and middle income countries. This study examines Pakistan vasectomy adoption barriers and the need for male-friendly family planning policies. Male participation and access to accurate information and services can improve maternal and child health and reproductive choices. So this is a graph that shows vasectomy condom and withdrawal method usage from 1975 to 2018 in Pakistan. As we all can see that condom usage has been increased and then it becomes stagnant. Withdrawal method has been also increased and become stagnant. The vasectomy usage has been increased and then it has declined in 2017 to 18 according to the PDHS Pakistan Demographic Health Survey data. The research question for this study are what are the interpersonal, intrapersonal, organizational, and systemic factors contributing to the low prevalence of vasectomy in Pakistan? How can male involvement in family planning be enhanced through targeted interventions? So this is the methodology. For systematic and literature review, I use 6 databases without year restrictions. For screening and charting, I use the Prisma framework. I had searched out 1,319 records which were screened, and then 29 studies were found eligible for this study. Data extraction. Data was analyzed using the socio-ecological framework, using a hybrid, deductive and inductive approach for analysis, and which is structured and multi-level findings. For thematic analysis, the socio-ecological model revealed layered barriers across 4 levels, which will be discussed in the results section. So the socio-ecological framework explains how a complex interplay of broader environmental, social, and policy influences shapes individual health behavior. At the intrapersonal level, uh, we find out the individual knowledge, attitudes, and belief, which leads to misconception about vasectomy safety. At the interpersonal level, we explore influences from family, peers, and social networks. At organizational level, we explore provider biases, lack of male-friendly services, and at policy level, we explored lack of national targets for male contraception. So, results. The study, guided by the socio-ecological model, identifies a layered set of barriers contributing to the low vasectomy uptake in Pakistan at the individual level or at the intrapersonal level. Misconception about sexual dysfunction, loss of masculinity, permanent infertility, along with limited knowledge and a desire for more children emerges as major deterrents. However, factors like economic pressure, concern for women's health, and positive experiences shared by satisfied users were noted as individual level enablers. At the interpersonal level, male involvement is hindered by the spousal disapproval, peer pressure, religious misinterpretation, and socio-cultural norms that frame contraception as a woman's responsibility mainly. Despite this, facilitator such as joint spousal decision making, support from peers, visibility of male champions indicate pathways to increase acceptance. Male champions were those who had used or adopted vasectomy and had a positive outcome, and they were giving a positive influence to the people or the community wherever they were living. At the organizational level, barriers were At the organizational level, barriers include limited service availability, a lack of trained and gender-sensitive providers, provider bias, and the absence of male-friendly counseling service spaces. Nonetheless, community outreach led by male mobilizer and targeted awareness activities show encouraging potential to shift attitudes. At the policy and system level, the dominance of female-centered family planning programs and services, discontinuation of male-targeted programs, and insufficient funding reflect the lack of strategic priority for male contraception uptake. Emerging evidence suggests that the use of social media, community influencers, and integrated service delivery models could serve as scalable enablers of effective intervention. Overall, the findings underscore the need for comprehensive, culturally appropriate, and multi-level intervention to address systemic and social barriers and foster greater male participation in family planning through vasectomy. So this diagram represents the results, which shows the barriers and enablers to vasectomy uptake in Pakistan. So the enablers was the partner support. If there was spousal communication, discussion between the couple, then there was a positive impact and there was uptake of vasectomy. If there were community outreach program available, government has placed some medical camps in which the vasectomy services were available, so people were opting it out. But those areas where there was no service provider, no one was there to give awareness, so myths and fallacies were highly there, and they were a significant barrier that was impacting the uptake of vasectomy. However, the policy focus has been very much limited in our context of Pakistan that promotes male involvement or engagement in family planning program as a user or client. Knowledge contribution. This study makes a significant contribution to the understudied area of male sterilization in Pakistan by providing a structured, multi-level examination of the complex factors influencing vasectomy uptake. Utilizing the socio-ecological model, the review offers a holistic understanding of how individual misconceptions, socio-cultural norms, healthcare system limitation, and policy level gaps collectively hinder male participation in family planning. Unlike previous studies that primarily focus on female contraceptive method, this qualitative review shifts the lens to men as active users and decision makers, identifying both barriers and enablers specific to the Pakistani context. By synthesizing insights from academic literature, resources, and program evaluation, the review shed light on key missed opportunities in policy implementation, service delivery, and community engagement. It emphasizes the need for gender equitable programming, male inclusive counseling services, and culturally relevant outreach strategies. The findings serve as a foundation for developing targeted interventions and will inform future research, advocacy, and policy efforts aimed at normalizing vasectomy as a safe, effective, and responsible contraceptive choice for men in Pakistan. And for recommendations to enhance male involvement in family planning program, we need to deliver gender specific service delivery. We need to have more vasectomy facilities. There should be information exchange and recruitment of male service provider training to reduce stigma. Thank you. This is my email address. If anyone wants to reach me out, you can reach me out at this email address. Thank you.
Thank you so much, Dr. Yolia, for the great presentation And now allow me to invite next speaker. We should have Adewale. And sorry, I'm coming in on behalf of the moderator, who we couldn't join. So I was just here as a tech support, but here to support you all. Right.
Thank you so much. I don't know if you could see my slide.
Yeah, we could see them. Many
Excellent.
thanks.
Yeah, thanks so much for my co-presenter's presentation. I'll be talking about introducing new products in resource constraint settings. We are showcasing the lessons we've learned from a scalable model in the Pacific Island countries. I'm presenting on behalf of my co-colleagues. Dr. Titi should have been making this presentation. Just to give you some background, contraceptive access remains a major challenge in many Pacific Island countries. Oftentimes, you will find that these areas, these regions of the world is often not represented in many of our discourse on family planning globally. And that's why we are so excited to have gotten a chance to make this presentation. 60% of Pacific Islanders live on outer highlands or rural atolls, yet hospitals and specialists are usually clustered in the urban centers. So we found out that most rural residents therefore face long journeys to access care and lower service levels. So the remote islands experience irregular shipments as well, so that medical health supplies and contraceptives are often challenging in getting to the last mile. We also found really deep prevailing norms and cultural values of large families, and the desire for this region of the world to expand the family so that they can have some relative population advantage because they're quite small, geographically located places. So they believe that large families and children are a gift from God. So this misconception often creates some resistance to contraception. So DMPA-SC came in as a self-injectable, this depomedroxyprogesterone sub-Q, that's what I mean, came in as a self-care method that will help to reduce the burden on healthcare systems and also empower women in terms of autonomy. So, however, the challenge we had is the fact that introducing new contraceptive methods often requires substantial investments in infrastructure, in policy, in training, and so on, which often are straining in terms of limited resources, particularly in these island countries. Right. So the project, more or less the investment has been carried out in 4 island countries in Fiji, Solomon Islands, and Republic of Marshall Island, and Kiribati. These challenges in these areas, we found that are often amplified due to the geographic isolation and the resource constraints, as well as logistical complexities that you have in terms of access in these geographies. So UNFPA decided to implement a phased approach to introduce and scale this method, leveraging on existing health systems to optimize resources. This helped significantly in minimizing costs and also has helped in terms of ensuring sustainability. So the integrated focus model provided a scalable and cost-effective framework for new program introduction. That's why we felt it's something we should share at a forum like the ICFP. The program goal was to integrate depomedroxyprogesterone acetate subcute as one of the options of long-acting reversible method, ensuring that we sustainably put it within the national health system, leveraging existing systems like policy, supply chain, training, and data systems, while we try to accelerate access at reduced costs. So how did we do this? Our approach was to look at 3 broad strokes, starting with a deep engagement with the governments in these countries. And we had to conceptualize what's the best approach to doing this. And we started with what we call the co-design workshops or innovation laboratories that involved government officials, involved partners, and also major stakeholders that had some stake in family planning. This workshop created an avenue for UNFPA to engage with them to ensure that there was a locally adaptable solution for each of those countries that I've just mentioned, in all those 4 countries. Those co-design workshops gave us a breadth of what are the best approach to leverage existing systems in those countries in such a way that we have the most cost-effective way of introducing the product. Most of what we did aligned policies, with existing policies. So there was a deep engagement at the startup. The system building phase involved integrating this method into existing family planning curricula. And that involved not just a standalone training like you have for most areas of the world. I think in most geographies where I've worked, I've seen that there's always that phase where there's that startup in which there's just training for just DMPA-SC as a single product. In the Pacific, what was done was to integrate into existing family planning curricula as well as supply chain so that it was easy to take off and also be able to add that into the existing family planning data systems. So there, as we're cascading, as the government was cascading out trainings, it was easy to add this method into those trainings. Also, similarly for demand generation. We looked at 4 broad areas in terms of component, and I think policy and regulatory framework was one major entry point. What we did was to embed this within the existing framework so that we could get simple waivers from the government to allow these products to be imported. For many parts of the world where this product has been produced, there are often more complicated process of regulatory approvals where you go through embedding within the essential medicine list and a lot of advocacy to get within regulatory and policy development frameworks. Also, investments in also things like developing guidelines and all other materials that many countries have done. In the Pacific, it was easier because the government was the driver and they had actually identified all of these broad stroke areas and agreed on exactly how to do that. So in their case, all we got were just waivers from governments to allow this product to be imported. And we went ahead to work with the drug and therapeutic committees to include that within the essential medicine list. These were not really very capital intensive processes because these most of those who were in these innovation labs were people who were sitting on the different committees that were responsible for all of these different areas. Like I said, the capacity building, we had to just integrate that into the broad family planning trainings. So they were rolled out. Once the TOTs were done, the government was responsible for the next level of the cascade. And we found a very high level of proficiency in terms of knowledge and skill transfer. Supply chain also, was integrated. And these were put within the national commodity supplies so that from the importation to the warehousing to the last mile were all easy to do. They went through the routing government systems. For data, UNFPA supported with some revision to their data systems so that this product could be introduced as part of the documentation process for those countries. I think I've spoken about this. So for training, just to showcase the fact that, from adapting materials that were locally owned, we found out that it was easy to look at the training curriculum and actually include this product within the broad spectrum of products that were already existing. And as trainings were being done, this was rolled out following the TOT, which was the only investment that we had. The next level of trainings that were done by the government as they were rolling out other family planning training within their different geographies. So, training cost was markedly reduced. And we found a high level of proficiency after each of those training, even at the cascade level as we were monitoring the progress with them. So I think integrating into existing logistics system is helpful. Just to make these quick points in terms of efficiency, there's a lot of significant savings that we can have in training and administrative costs if we're able to leverage government involvement right from the outset. We're able to minimize challenges with costs. We also enhance value for money through integration. I think the most important thing we found is it reduces duplication and minimizes stockouts, which is the major leverage or yardstick with which we measure any family planning program. So integrating DMPA-SC into the existing logistics system was quite helpful for this process. The lessons we learned, I think, are spoken extensively about integration. Also, the fact that with capacity building, adapting global training materials was helpful. To the local context was helpful. It ensures scalability and ownership. I think for the policy alignment piece, it was helpful to just look at existing processes for their normal policy review and make sure that there were people sitting in those policy review processes who could speak out in terms of ensuring that this product is actually detailed as they were working around some of the policy-related things and help to accelerate the regulatory approvals as well. I think I would probably highlight the fact that collaborative partnership is key, ensuring that we align with local and global stakeholders also helped us to ensure commitments and facilitated the efficient use of resources. This is a scalable model, we believe, which countries can adopt. And we're happy to share many of the resources that we used because oftentimes new product introduction remains quite prohibitively expensive. And we are still working on some of understanding some of the cost leverages and trying to put together some of those cost indices to understand how much the dollar amounts for all of those processes. I'll be happy to share when they are ready. So, I mean, this offers a blueprint for resource constraint context globally. And we believe that leveraging existing health systems and infrastructure will ensure a sustainable, equitable, and cost-efficient access to contraceptive innovation. The Pacific Island experience offers a model for global family planning programming, and we wish to highlight that the transformation we should see, because once in every decade we see a new product come up, looking at areas of resource constraint and how we can have this kind of system integration is one very helpful way to reduce costs and also helps government to hone the process in the long run. I think finally, just to showcase our contacts, mine is the second one. Please feel free to reach out to us if you need any further details. We also wanted to thank the Ministry of Health in these 4 countries and the committees that participated in the program. Thank you for the opportunity to present this.
Thank you so much, Adewale, for the great presentation. And I think without taking time, I would invite the next speaker, who is Neha Srivastava, to also take the stage. And I think Neha is going to be our last speaker for this session. So I really encourage participants to feel free to post their question in the chat using the Q&A function or through the chat, so as presenters can be ready to speak. Neha, you have the floor.
Thank you. Thank you so much, Innocent. Actually, we are co-presenters, so Ashutosh will be going first. I'm just sharing my screen.
Thank you, Neha. Maybe you can put it on the presentation mode.
Yeah.
Thanks. Yeah. Hello, everyone. Thank you once again for joining this session. I am Ashutosh Kaushik from Foundation for Reproductive Health Services, India. We are an affiliate of MSI Reproductive Choices. I'm delighted to share our experience on how, we have been advancing gender equality by bringing more and more actively into family planning conversations, particularly through promoting non-scalpel vasectomy or NSV in the state of Rajasthan in India. Our work is part of larger efforts to make family planning more inclusive, to shift the focus from being woman only to bring a shared responsibility between partners. Can we move to the next slide, Neha? Yeah. So the problem, of course,
yeah.
a couple of presenters have already highlighted, we are also falling at the same criteria. In India, family planning has long been viewed as a woman's responsibility. It is deeply gender imbalanced. I mean, if we look at the data from the National Family Health Survey, female sterilization continues to be the dominant, and it is accounting for 38% of method mix in India, while the male sterilization accounts for less than 0.5% of the total contraceptive use. I mean, similar statistics were seen in Rajasthan when we intervened. Even though the awareness of male sterilization is high, more than the 90% of men have heard of it, but very few actually consider it. We all know that NSV is safer, simple, and most cost effective than a female sterilization, which accounts for 38% when it comes to method mix, total method mix in India. I mean, promoting it can redefine the gender roles and demonstrate that the contraception isn't about gender, it's about shared responsibility and choice. Can we go to the next slide, please? Yeah. Yeah, that's right. So, one of the biggest barrier we face is that lack of awareness, as I was just telling you, it's misinformation. Across communities, we repeatedly hear myths like vasectomy makes men weak, it's affects sexual performance, or even it makes you infertile. Combine that with very few trained providers, there is already a scarcity of providers in India for vasectomy and the limited service availability. We end up with the situations where men stay away. What this means is we are missing an enormous opportunity for gender equality. Our approach at FRHSI India set out to change that by making services accessible and information trustworthy. So with that, we can move to the next slide. Yeah. So what we did, I mean, we used a very simple but a very powerful three-part strategy. First, expanding access. We made NSV services available not just only to our clinics, but through mobile outreach team that's traveled to a government health facility across districts, so that the geography won't be a barrier or a burden for the seekers. Second, increasing awareness. We actively address myth through information campaigns, community meetings, and local champions who people already have trusted, have gained trust from the community. And third, which is again very important for this intervention, is driving engagement. We built a network of NSV champions, men who had undergone the procedures and were willing to share the stories publicly. So we can again move to the next slide in the interest of time. Yeah. So again, the community engagement was key for us. We partnered with wide range of community figures, teachers, ashas. Ashas are basically the frontline workers from the government side, village leaders, influencers, to reach men through voices they already trusted. And we were able to target very well. For example, our outreach team members began engaging on a daily basis to the daily wage laborers in the early morning market, where they gathered to search their work opportunity, literally meeting men where they are. So with this background, I would now request my colleague Neha Srivastava to take you through the efforts that we have taken for these interventions. Over to you, Neha.
Thank you, Ashutosh. So we will discuss a little about how we did it. First, a little introduction about me. Hello, everyone. I'm Neha Srivastava from FRHS India. And the methodology that we followed for our intervention was between 2022 and 2024. We rolled out these interventions across 23 districts in the state of Rajasthan in India. Our services were delivered in two ways through six FRHS India clinics and 13 mobile outreach teams. These mobile outreach teams, we call them clinical outreach teams or COTS, and they're fully staffed, fully equipped, and they visit public health facilities on a pre-planned schedule. These mobile outreach teams, they provide the complete range of family planning services, including vasectomy or NSV services. And over time, they become a part of the public health system instead of becoming a parallel system. To measure the impact of our reach, we looked at our service delivery numbers, but beyond that, we also compared FRHS India service delivery data with the government state level data to understand the contribution or the proportion of total vasectomy cases or uptake and the contribution of FRHS to that number. We also calculated the couple years of protection or CYP to translate or understand the impact our services had on contraceptive impact. So if we talk about the result, what we achieved was that between 2022 and 2024, FRHS India provided vasectomy services to more than 2,400 men. That was almost 41% of all male sterilization that was done during that period in the entire state of Rajasthan. And this was achieved by FRHS by only operating in almost half of the districts in the state. In 2022, we contributed almost 42% of all NSVs in the state. In 2023, the proportion of FRH's contribution rose to 48%. And even in 2024, where we had observed an overall decline in state level numbers, the uptake of NSV or vasectomy had declined all over Rajasthan, and yet FRH's contributed to one third of those figures. If we talk about CYP or couple years of protection, the service delivered by FRHS and the men who took up NSV, it led to a generation of over 31,000 CYPs, which meant thousands of families gained reliable and long-term contraception. For calculation of CYP, we use the conversion rate of 13 CYP per procedure, which is the standard used in India, Nepal, and Bangladesh. But if we talk about that, these numbers, they do tell us a story. They're only part of the story. There's much more to know beyond that. So what really mattered beyond these numbers was what had changed under the surface. Because of the regular outreach visits, that it had a very system strengthening impact. It ensured regular, reliable, and high quality vasectomy services were provided at public health facilities. So NSV, where earlier NSV services were considered rare, they became routine. And that's why people knew that if they visited facilities, there was a much higher probability of them receiving the services. In communities, we observed open conversations which were led by NSV champions and other influencers that were part of a network. And this open conversation helped to shift the tone from fear to acceptance. This led to building community trust in the process. So we began seeing men asking questions, becoming curious, and not just dismissing the idea of getting a vasectomy. Our outreach efforts, which focused on daily wage laborers, meant their inclusion. Usually, this is a very niche and underserved group that gets overlooked during most outreach efforts. So, because we did targeted outreach efforts for them, we saw more voluntary NSV uptake in this niche group. So if we have to talk about one takeaway from this experience, it is that if we are talking about increasing male engagement in family planning, we will require a multi-pronged strategy. Access alone will not be enough. We can't just open services and expect men to show up. We need awareness, we need reliable, relatable information that challenges myth, and we also need trust, which is built through people and stories that the communities believe in. Our mobile outreach model ensured accessibility. Our champions and our campaigns built awareness and confidence, and our community partnerships created trust in the communities that we were working. So, what does this mean going forward and for other programs across the globe? Firstly, what we understood was that the approach followed by FRHs is scalable and replicable. Our outreach model that uses the mobile outreach teams, it is, and especially if we are talking about outreach models that can be integrated within the public system, it is very easy to replicate this model and also scale up the model. And what it ensures is that it expands access to NSV and other male focused services, especially in underserved geographies. Secondly, community mobilization, especially by engaging with champions, it's not just an awareness tool. It is a trust building mechanism that normalizes discussion on male sterilization, and it almost makes participation by men aspirational. And thirdly, the if we are talking about community engagement, it has to be inclusive. And that was something that we observed through our targeted outreach, which ensured that we met men where they were at. So it and this showed that if you are taking or going that extra mile to reach men where they are at, it will go a long way in promoting voluntary participation in family planning. So, with that, we come to an end of our presentation. And to close, I'll just like to say that male engagement should not be in family planning should not be considered optional. It is necessity, it is essential if we truly want gender equity. And what we saw in Rajasthan through the FRHS field experience is that when you meet men where they are, give them reliable services and let them hear from peers who had also gone through the same process, it is, the change happens. And we saw the change firsthand. And we are hoping that everybody who's here with us in this session, they're able to take these learnings with us, and it hopes to be helpful in case they are planning to implement pilots or programs. Thank you. And our contact details are mentioned in this slide. If you have any questions, if you want to have more details about our work, you can also visit our website, and our email addresses are also mentioned here. So thank you very much.
Thank you so much, Neha and Ashtoshi for the great presentation right now. So I know we have time remaining. We're supposed to end in the next at least 40 minutes, so we can allow for questions. And I'm trying to see if there is any question posted in the chat, but there's not any question. But also I'll allow for if any of you have any additional presentation that they want to share, we still have some time before we end this session. And for participants, please feel free to use the chat and drop your question there. Any question? I believe we can ask questions amongst ourselves as well, presenters. Great. If there's not any question, then maybe we can, I can invite each one of you to, if you have any additional points you want to share before we close this session. Yep, and a group photo, that'll be amazing. I can do a group photo and then send it to you if you open your mic, you open your videos with the email. You can only see, there we go. Okay, how can I make a good view to do the photo here? Oh, I got it. And you're going to excuse me because I'm shy opening my video. I've been on so many Zooms since morning. I feel my face is looking tired, but I'm going to do it for you all. Took one and then took another one. Great. I'm gonna I'm going to email you these photos so you can share to our networks. Otherwise, I really appreciate your time, and many thanks for presenting these really great findings to the conference, and really honored to be a supportive team for this section.
Thank you.
Yeah. Many thanks.
Thank you so much, Innocent, and thank you so much, everybody who joined us. It was such a great and insightful session. Thank you to all the presenters as well. Great learnings that we got to hear today.
Awesome. Thanks, everyone.
Thanks, everyone.
Thank you. Thank you
Thanks
so
for
much,
everyone.
everyone, for sharing your presentations and letting us know what work you all are doing for male engagement in your areas. It was really good to hear from you all about the work that you are doing for male engagement and gender equality. Thank you.
And just
Thank you.
to add, we'll be sharing the record of this section as well later. So please take a look at that. And there will be a survey that is going to be sent to all of us. So would really, really appreciate your feedback for improving future conference engagements. Over to you, alternative host ticket.
Thank you, colleagues. It's
All
time
right.
to sleep here now. I have to sleep.
So here it's
Yeah.
2:15 in India.
Oh yeah, it's already late.
2:15 in the
Maybe.
morning.
1:45 a.m. in Pakistan right now.
Wow. It's just 3:48 in Bogotá. So still
We
early.
all have had a long night, but it's been very rewarding so far.
Thank you so much, everyone.
Thank you. We will
Thank
reach
you.
out to you for further questions, and do reach out to us. Do visit our website. Thank you so much. Bye for now.
Bye, everyone.
Thank you,
Bye.
everyone. Bye.
Bye,
Thank
everyone.
you. Bye.
Thank you,
Bye.
Innocent.
Many thanks. Bye, everyone.